Good evening. Welcome to another Embedded Racism in the Law panel discussion presented by the Diversity Committee at Vermont Law School. Tonight's discussion is on the focus of the disparate impact of COVID-19 on people of color. This week marks the tragedy of over 500,000 deaths in the United States to COVID-19. Please join me in a brief moment of silence to reflect and honor those lives lost. Thank you. This pandemic has affected everyone in some way. However, it has affected communities of colors disproportionately. According to a new Center of Disease Control Prevention report, data through June 2020 shows life expectancy at birth for the total US population fell from 2019 by a year to 77.8 years, the lowest it has been since 2006. Life expectancy for the Black population has declined from 2019 by 2.7 years to 71 years of life, the lowest it's been since 2001. Latinx experienced the second biggest decline, falling from 1.9 years since 2019 to a life expectancy of 79.9 years. To discuss the intersectionality about why this is happening, we have 4 experts from across the country joining us today. First, we'll hear from Dr. Geno Tai, who is an infectious disease physician trained at the Mayo Clinic. Their research has focused on bone and joint infections, diagnostic stewardships, and implementation of science. Currently, they are an instructor of medicine at the Mayo Clinic and graduated with a doctor's of medicine. Second, we'll hear from Professor Wendy Parmet, who is a leading expert in health, disability, and public health law, is the director of Northeastern's University Law School MPH program with Tufts University School of Med and the Center on Health and Policy. She is the professor of public policy and urban affairs at Northeastern University. She is also the co-author of Northeastern's SSR and online publication, Human Rights and Global Economy, in the Northeastern University School of Law and Legal Theory research papers. After that, we have our own Professor Mark Latham, who has joined the VLS faculty back in 2005 after 15 years of private law. Since joining the VLS faculty, Professor Latham has taught a variety of courses, including torts, business associations, environmental law, environmental issues, and business transaction, use of force, and co-taught cybersecurity. He has spent several years in the administration of the school as Deputy Vice Dean for Academic Affairs and as the Dean of Students. His scholarly interests include the intersection of business and environmental law. He has received his undergrad degree from Illinois Wesleyan University and a JD from University of California at Berkeley. And then finally, we will hear from Dr. Mercedes Avila, Associate Professor of Pediatrics at the University of Vermont Larner College of Medicine. She provides consultation and trainings on diversity, equality, equity, inclusion, and has trained more than 10,000 providers across 27 states, 150 organizations. Since 2011, Dr. Mercedes has been invited to lead 58 national presentations and 100+ regional sessions on topics related to national class standards, health disparities, social justice in healthcare, racial inequality, and human health. She has received 14 national, regional, and state service training research awards for her work in equity. Each of the presenters will have an opportunity to present their information and talk. Then we will open up for Q&As after the presentations. If you have a question, please submit it in the chat and we will answer it at the end of the presentation. I would now like to reintroduce Dr. Geno Tai.
Sorry, I'm muted. Okay, now let's do that again. Okay, trying to make this work. Okay, perfect. Good evening, everyone. It's a pleasure to be here. Thank you for inviting me. My name is Dr. Tai. I'm an infectious disease provider at Mayo Clinic here in Minnesota. Pronouns are he, him, his. So I have no disclosures. I have nothing to disclose. And just for reference, the data in this talk is up to January 31, 2021, and some up to February 16 of this year. I want to start off with this famous guy, the New York governor. He said, everyone is subject to this virus. It is the great equalizer. I don't care how smart, how rich, how powerful you think you are. I don't care how young, how old. The virus is the great equalizer. So it's kind of true what he said. COVID has been touted initially as a great equalizer. To some extent, it's true. But when we look at the demographic trends of patients in the US, we see 21% of those that were affected are Latinx, and then 12% are Blacks. And then deaths are 13% for Hispanics or Latinx and 15% for Blacks. Remember that Blacks make up 13% only of the population, and then Latinx are 18% of population. And what we are data here are just 74% available. So we're not reporting 100% of the time. This has gotten better since June 2020 when the CDC reported initially that 22% were Blacks and then 34% were Latinx. Right now, at this very moment, these numbers might not be very stark. But if you look at other key statistics, and I'll just run this through so you'll see, 1 out of 45 Indigenous Americans have died, 1 out of 165, 1 out of 66 Pacific Islanders, and for among whites, it's 1 out of 825. And here are the other numbers. Now, when we look at age-adjusted rates, meaning comparing age groups together, we'll see that Pacific Islander, Latinx, Indigenous Americans, and Blacks are 2 times more likely to have died of COVID-19 than white Americans. So why is that? I've stumbled upon this comic strip Pogo by Walt Kelly, and it's basically, he said, we have met the enemy and he is us. I think this is very apt with whatever is happening nowadays. It's a good place to start and say that it's structural racism and systemic racism that's causing all of this. And I want to say this very early on. Now let's go through some of the biomedical lenses that causes this disparity. We know that comorbidities significantly increase risk of mortality from COVID-19. Comorbidities such as hypertension, diabetes, congestive heart failure, chronic kidney disease, and cancer increases your risk of dying from COVID-19. And we know that Blacks have been disproportionately, there's a disproportionately high prevalence of such comorbidities. And they're also more likely to die prematurely compared to whites. Other than that, the uninsured rates among non-elderly Blacks and Latinx Americans are also significantly higher. 22% of Native Americans, 19% of Latinx, and 12% of Blacks are uninsured compared to 8% of whites. They also tend to live in areas where medical care is poor or medically underserved. Now let's talk about social determinants of health. We define these as conditions in the places where people live, learn, work, and play that affect a wide range of health risks and outcomes. So poverty rates are higher among minorities in the US. It's more prevalent among communities of color. 24% of indigenous Americans are in poverty, 22% of blacks, 19% for Latinx. That's compared to 9% of whites. And the median wealth, this is a start, really stark. Like median wealth of white households is 10 times more the wealth of black households. Let's talk about work from home. Only 20% of blacks and 16% of Latinx can work from home, compared to 30% of whites and 37% of Asians. And African Americans make up 40% of transit workers. Also so you can see this is the slide here for the rates of people who are working from home based on the racial breakdown. And you can imagine 75% of frontline workers in New York City are people of color. Let's switch gears and talk about the meatpacking industry. We know that this industry already has a lot of controversies, particularly with safety and welfare, even before COVID, for their workers. So we know that 50,000 meat packing workers have been infected and at least 250 has died, according to a tally. Many meat packing workers don't speak English. They aren't granted paid sick leave. Managers from a plant allegedly ordered workers to stay on the job and then place bets on how many would contract the virus. And then let's move on to some more social determinants of health. We know that communities of color are likelier to be in higher housing density, more housing insecurity, scarcity of potable water, and more multi-generational households. Also, their communities are more likely to be food deserts. This is defined by the government as living more than a mile from a supermarket in an urban or suburban area, and more than 10 miles from a supermarket in a rural area. So we made this triangle from our paper. When we have a pathogen such as SARS-CoV-2, which is the virus, the official name for the virus for COVID-19, you will see here that you have the host factors, which are chronic diseases, malnutrition, poverty, which are affected by the environmental factors such as systemic racism, housing density, pollution, where they are, reliance on public transportation, and such the other variables. So these inequities were put in place by design, because I like this great title to an article published by my colleagues in JAMA. They say that racism, not race, drives inequity across the COVID-19 continuum. And you could imagine the legacy of redlining, housing segregation, all played a role in this current problem. I have just a few more slides on this topic. I'm gonna maybe use some more time for this topic because this is like a hot topic at the moment. These are the current numbers for COVID vaccinations among Blacks. And you can see vaccinations are lagging among communities of color. And some states, the gaps are massive. For example, the ones I highlighted here, where the percent of vaccinations and then the percent of cases, deaths, and percent of population all outpaces the percent of vaccinations. And this is the vaccination numbers among Latinx. You could see here, California, 55% of cases, 46% of deaths, 40% of the population, but just 18% of the vaccinations. How about Florida? 37, 24, 27%, only getting 16% of the vaccinations. And also Texas. So you could already see these mostly across the board, you will see the disparities. And these are just some. And there's a consistent pattern that Black and Latinx are receiving smaller shares of vaccinations compared to their share of cases and deaths, and also, of course, to the share of the total population. And we have to take note, though, that these data are very preliminary. Only 34 states are reporting, and the states vary widely on how they are reporting this. And also, like, for example, the data reported, the reporting periods, the racial classifications, or some, like, high rates of unknown, they would classify as unknown race or ethnicity, and that's accounting to 45% of the data. They also vary in whether they report total doses of patients with 2 doses or 1 dose. So it's not very clear. These data raise early concerns about disparity in vaccination, but are subject to inconsistencies, which basically limit our ability to draw conclusions right now. It's definitely a signal we should keep an eye on. So that's my presentation.
Thank you. Next, we have Professor Parmet from Northeastern.
Thank you so much. I really want to thank all the organizers for inviting me to speak with you today. I'm going to talk about as allowed to enter the country freely from those areas without any quarantine or inspection. Even today, immigration law and health policy are being commingled as the CDC has blocked asylum seekers from Mexico on public health grounds. Immigration law has also exacerbated the pandemic by forcing thousands of non-citizens into prisons and detention centers, which have been called by federal judges as tinderboxes of infection. Although some efforts were made early in the pandemic to reduce populations in detention, the efforts have been relatively marginal The data keeping is poor. We do not really know the full story of how many have been sick and how many have died in immigration detention facilities. But I want to focus for my remaining time on a different mechanism through which immigration law intersects with structural racism to harm the health of immigrants and the broader community. And that is by restricting access to positive social determinants for health. First, it's important to acknowledge that we don't know the full scope of COVID-19's disparate impact on immigrants. States do not report case data by immigration or nationalization status. Nevertheless, communities with high levels of immigrants, especially Latinx immigrants, have suffered disproportionately from the pandemic, as we've previously seen. And it's also worth noting that among immigrants, Black Latinos have suffered the highest toll. In thinking about such information, it's important to remember also that we need to not only think about immigration's impact on immigrants, but immigration's impact on the broader community and the community in which they live. Indeed, about 13% of all children in the US live in mixed status families. So policies that harm the health of non-citizens inevitably harm the health of citizens. So how does immigration law heighten the vulnerability of such communities? I can't begin to cover all the ways, but let me mention a few. First, and perhaps most important, it's by denying access to critical social benefits. In 1996, Congress passed the Personal Responsibility and Work Reconciliation Act, which generally bars undocumented individuals from accessing most federally funded benefits and blocks even lawfully present non-citizens, green card holders, for eligibility for the first 5 years in which they have such status. Per ora is a complex law. There are many exceptions and exceptions to the exceptions. And further subsequent laws have complicated the picture even further. But there's no doubt that per ora has made it very difficult for non-citizens to access Medicaid, the Children's Health Initiative Insurance Program, SNAP, better known as food stamps, TANF, and housing supports, thus increasing their social vulnerability. The ACA expanded immigrants' access to health care, but it left many holes in place, including those created by per ora. It also imposed significant verification requirements designed to deter undocumented immigrants. And the Obama administration ruled that DACA recipients were not eligible to participate. Largely as a result of these laws, immigrants of every status are far less likely than native-born citizens, even before President Trump took office, to have health insurance or a usual source of care. Once in office, President Trump undertook a series of policy changes that fortified the barriers. These steps include increased enforcement, further deterring immigrants from accessing benefits that they were legally entitled to, and also in promulgating the so-called public charge rule, which the Supreme Court allowed to go into effect last February, just as the pandemic was beginning to impact the United States. In brief, since the 19th century, the Immigration and Naturalization Act has required immigration officials to deny access into the country to individuals who are found likely at any time to become a public charge. I should add, it's not just access, it's change of status within the country. However, longstanding interpretations of this provision held that the use of non-cash benefits, such as health insurance, Medicaid, other than long-term care, does not render one a public charge. Under the new regulation, a public charge is defined as a non-citizen who receives one or more public benefits, including Medicaid or food stamps or housing supports, for more than 12 months aggregated in a 36-month period. Past use of benefits are considered heavily weighted negative factors in determining whether one is likely to become a public charge in the future. Lack of health insurance and a serious medical condition are also negative factors. Excuse me. On the one hand, because of all the federal barriers, very few non-citizens are actually eligible for all these federal benefits and subject to the public charge rule. But the rule was almost surely designed to and succeeded in instilling fear, letting immigrants believe, especially non-citizens, that if they access benefits, it would harm their immigration status. Studies have shown that non-citizens, even those not subject to the rule, have foregone or disenrolled from critical social safety net programs for themselves, for their children, their family. This started just as the pandemic began and the recession hit. So just when things got bad, non-citizens were deterred from accessing critical supports. On March 13th, 2020, the Department of Homeland Security issued guidance stating that it would not consider public support for testing, treatment, preventive care, including vaccines related to COVID as part of the public charge determination. But it did not suspend the rule, it did not publicize this guidance, and it did not state the use of other benefits, including health insurance for non-COVID related reasons, would not apply. So if somebody went to get care and it turns out they didn't have COVID, they might in fact have been hit. Many non-citizens were also barred from accessing some of the relief provided last spring by the CARES Act. For example, the $1,200 cash assistance the Act provided was limited to citizens and immigrants who have Social Security numbers. This barred citizens and legal permanent residents who are married to undocumented immigrants without a Social Security number from receiving relief. I should note that last December's Coronavirus Response and Relief Supplemental Appropriations Act overturned that. And while the CARES Act provided funds for COVID testing and treatment, regardless of immigration status, immigrants without insurance can face unanticipated bills if they are diagnosed with other conditions. All of these factors work alongside labor vulnerability. Think about the meatpacking plants, which we just heard about. Immigrants are disproportionately employed in low-wage jobs that don't offer health insurance, sick pay, and because of their fear of losing their immigration status or deportation, they are less likely to feel comfortable asserting their rights when they face unsafe work conditions. So how do we move forward? Has taken several important steps. He issued an executive order directing the Department of Homeland Security to review the public charge rule and to restore DACA and temporary protective status. Most importantly, he has supported and has put before Congress a comprehensive approach to immigration reform. This will provide a pathway to citizenship. But importantly, it doesn't overrule PERORA. It doesn't guarantee immediate access to critical benefits. And for many, even if this law passes, and in the current state of congressional politics, that's a big if. Even if it was to pass, many people are going to have to wait 10 years until they can access benefits. So let me end by saying again that COVID has shown a light on our strengths and our weaknesses. And one thing that it has shown us throughout this pandemic is that our unwelcoming immigration laws, our punitive immigration laws that attempt to really promote what Senator Romney once called self-deportation. And the idea is to make life here so inhospitable that people will want to leave. It has created enormous social vulnerabilities for non-citizens and for their families and communities. And it has made us all vulnerable to the pandemic. Thanks.
Thank you so much for that insight. Next, we have Professor Latham.
Thank you, April. Let me get this. Okay. So the title, well, first of all, before I jump into my presentation, I want to thank the members of the Diversity Committee for inviting me to speak this evening, specifically Sue Tipp. And April, we want to thank you for your help. And of course, Wendy, for your technical assistance for us Luddites like me. But the title of my presentation is Dying to Feed Us, the Disparate Impact of COVID-19 in the Food Production and Processing sectors. Now, what I'd like us to do is if we think back to the early days of the pandemic, toilet paper became quite the commodity. For some bizarre reason, Americans hit the stores and purchased as much toilet paper as possible in the early days of the pandemic. And there were indeed shortages in many places in the country. But the food supply, which was one thing that concerned many people early on in the pandemic, held by and large. I mean, there were some spot shortages, but by and large, we were able to go to the grocery store and buy food to feed our families, which is, of course, critical. Now, why did the food supply hold? And the answer is because of the men and women who work in food processing and production. And here we see what appears to be a beef processing line. And one of the things to keep in mind is just see how tightly packed these people are working. So we owe these good men and women a tremendous debt of gratitude for keeping us fed during this extraordinarily difficult time. Now, just to take a quick look at the meat and poultry sector, which is the largest sector of agriculture. But look at these numbers. I mean, these are startling numbers. This is 2017 production, and this is from the National Association of Meat Industries. But 9 billion chickens, 241 million turkeys, and on and on and on. So millions, actually billions of animals annually are slaughtered and brought to market for us to buy if we are not vegetarians or vegans. And that takes an enormous workforce in order to do that. And so there's literally millions of people employed in this endeavor. And close to 40% are involved in the animal production and processing side, 30% in the crop production, 7% in seafood, and then 25% in specialty food production, such as bakeries, beverages, and so forth. So millions of people. Now, here is the makeup of, or the demographics of this workforce. And right off the bat, if you look in the far right-hand column under meat processing workers, roughly 65% are people of color. So the meat processing industry, at least on the floor, is dominated by people of color. Now, who employs these people? Well, here are the 5 largest meat and poultry producers. Tyson Foods, JBS USA, which is actually owned by a Brazilian company, Cargill Meat, which is the world's largest private company, Cisco and Smithfield Foods. And then these 5 combined with National Beef Company produce by far the vast majority of meat and poultry in the nation. So this is a very large sector of our economy, and again, vital to feed us. Now, as I'm sure most people know or should know if you read The Jungle back in high school or college, meat and poultry processing employees face a significant high risk of injuries. It is very dangerous work. The plants are noisy, which contributes to things like hearing loss. They perform repetitive actions all day for many hours. So there's a high percentage of repetitive motion injuries, crushing injuries. And because they're working with a lot of sharp tools, knives and saws and so forth, amputations are fairly common, and asphyxiation. And in fact, there were, I think 5 or 6 employees at a chicken processing plant in Georgia just a few weeks ago were asphyxiated when there's a release of nitrogen into the plant. And so a very high rate of injury. And so it's a dangerous occupation, made even more so by COVID and this pandemic. And USA Today has done, I think, some really good reporting in this area, and noted back in April, just a few months into the pandemic, that there was a rash of coronavirus outbreaks at meatpacking plants across the country. What is noteworthy here, I think, is the fact that it was far more extensive than previously thought. At the same time, the federal government granted to 150 poultry processors waivers to cut chickens faster, which is usually accomplished by speeding up the line and including more workers in already fairly crowded production lines. And then just a few weeks ago, there was another article in USA Today which noted that COVID-19 deaths in the meatpacking industry have pretty much gone uninvestigated, and more about that later. So we really do owe these people a debt of gratitude because they have placed themselves at great risk to keep us fed. Now, the CDC in July confirmed what USA Today was reporting, and that 54,000 workers at meat and poultry packing plants had tested positive, and close to 300 had died. Now, those numbers, if you think about them, I mean, they're startling, but they don't tell the whole story, because now one might think that, well, 54,000 people were infected, 270 died, not so bad, certainly tragic for them and their families, but overall that's not so bad. But what these numbers don't tell us is how many of those 54,000 workers who are infected really are still struggling to recover from COVID. Because, it's my understanding, and the physicians on our panel can correct me if I'm wrong, but there's a fairly significant numbers of COVID patients who don't have the miraculous recovery and struggle for months after being sick. So these numbers don't really tell that story. They also don't tell us how many people in the community were affected by the workers who became infected. So that's also not known. And then the CDC also concluded in its same July 2020 report that 90% of those who had been infected in the states that reported outbreaks were people of color. So definitely a disparate impact on meat and poultry workers. And this quote really resonated with me when I read it, because it really reminded me of The Jungle, that quintessential book about the horrors of the meat packing industry at the turn of the 20th century in Chicago. And it isn't just how many have died, but who. The U.S. meat packing industry has long relied on vulnerable populations to fill its workforce: immigrants, refugees, people of color, and those who lack other employment opportunities. So it's always had an air of exploitation about it. Now, why are meat packing plants COVID hotspots? Well, the CDC took a look at this as well. And one of the main drivers is the close proximity of workers. Again, to produce millions of animals a year requires, again, a large workforce. That is one of the primary drivers of why meatpacking plants have been COVID hotspots. The duration of contact with a potentially affected employee is another problem. When you stand next to someone for 12 hours who may be infected, and you have insufficient PPE, that is a disaster waiting to happen. The type of contact is also a factor. And then also the fact that many people share rides, and there's also communal living in tight quarters, which helps spread COVID-19 too. Then other factors, the work environment. Many portions of a meat packing plant have to be kept fairly cold. You can't have temperatures above 40 degrees. So the virus, I understand, can linger longer in cooler temperatures. There's language barriers, immigration status, which Wendy alluded to, can be an issue. Lack of access to healthcare or lack of health insurance, which Dr. Tai mentioned, and then also fear of job loss. Many of the meat packing businesses told their employees that, look, if you get sick, you still have to come to work because we have to feed the nation, if not indeed the world. So fear of job loss is another factor. Now, what did the industry do? Well, as was well publicized, there are a number of plants that ended up being closed and cleaned throughout the country. They put up barriers between workers, provided masks and face shields. They, in some instances, slowed the line speed down so that they weren't, so you could have fewer people working the line. They modified break rooms and locker rooms, staggered lunch times, and changed benefits and offered increased pay and bonuses for their employees. At least some of the so-called meat majors did. But they also worked the DC connection. And I find this a very telling slide. So in 1999, the lobbying expenditures for the meat processing industry was roughly $500,000, a mere pittance today. And now that number has climbed dramatically in 20 years up to over $5 million. And on the 2018 midterm elections alone, they spent $1.3 million in campaign contributions to influence the election. Now, this I find particularly interesting. So on April 27, 2020, Tyson Foods placed a full-page ad in a number of papers, including the New York Times and the Washington Post. And the chairman and CEO noted that in communities around the country where we employ over 100,000 hardworking men and women, we're being forced to shutter our doors. This means one thing: the food supply chain is vulnerable, which is and again, this is fairly early on in the pandemic, just a couple of months in. And this is a terrifying thought that, boy, maybe we won't have enough food in our country. And in an interesting coincidence or an instance of collaboration, the very next day, April 28th, former President Trump declared meat processing facilities critical infrastructure under the Defense Production Act and directed the USDA to work with plants to keep them open. And Geno alluded to this earlier, where many workers who are of color can't work at home, and you can't do meat processing at home. So these people absolutely had to go to work. Now, what happened at the regulatory level? Well, shortly after President Trump deemed the meat processing and packing industry critical infrastructure, and therefore they had to stay open, the OSHA and the Center for Disease Control issued joint workplace recommendations. So these were not regulations, and they're frankly pretty weak. One, they were voluntary, but they also were replete with language such as social distancing, quote, when possible, modify production lines, quote, if feasible. And so not really a firm guidance that the meat processing industry had to follow. Now, if you were to go back to 2009, where there's an H1N flu epidemic, and look at what the CDC did and what OSHA did too, how they responded, it was much different. And what happened in 2009, OSHA did not have a standard in place that was specific to the H1N1 flu. So what they did, and what I think was a somewhat brilliant application of keep it simple, they adopted a rule that basically said, look, meatpacking industry, you have to comply with the CDC's recommendations. And so they made it mandatory. That didn't happen with this pandemic. But OSHA is also way out, understaffed and under-resourced. So there's 2,100 inspectors, there's 8 million work sites and 130 million US employees. So the ability to inspect is just extraordinarily difficult. Now there have been 2 OSHA fines that I found after deaths at some meatpacking plants, and the fines as a result of these deaths were I mean, they're embarrassing. I mean, $13,000 and $15,000, and at both these plants, these were instances of multiple deaths. Just the cost of business, I assume. But anyway, so the very weak regulatory response to keep these, try to keep these vital employees safe. Now, there have been some litigation that's initiated, and this is what really got me interested in this area was because I figured there was going to be tort suits, and there certainly have been. But one of the first, if not the first, involved a interesting claim. It was a claim that because of the failure of the Smithfield company to really implement protective procedures at its meatpacking plant in Milan, Missouri, that it was a public nuisance. And they wanted the judge to issue an order that the plant had to comply with the CDC guidance, which was granted, but the judge ultimately dismissed the case, finding that OSHA had primary jurisdiction and not the courts. And so that was the end of that case. But there have been some other legal actions as well. There has been a administrative complaint that was filed with the USDA alleging that Tyson Foods violated Title VI of the Civil Rights Act through their anemic COVID-19 workplace policies. And I believe that suit is still in the administrative process. There is also a complaint filed with the FTC, or a request filed with the FTC, the Federal Trade Commission, to investigate Tyson Foods for allegedly making false and deceptive advertising claims about its, quote, safe working environment and independent farm claims. And that is still underway as well. Then there's also been a number of wrongful death actions that have been filed on behalf of meat processing employees who have died, alleging wrongful death or gross negligence. One of the first ones that was filed is this Bulgic v. Tyson Foods, which is an interesting case because it is in the complaint, there's three individuals who are the estates of the individuals are being prosecuted all in one single complaint. But what's particularly noteworthy about this, and this suit arose out of the deaths at the Waterloo, Iowa plant of Tyson Foods, which is the largest pork producing plant in the country. But among the allegations in the complaint is the fact, or not the fact, the allegation that the plant management, the manager of the plant, had a betting pool on how many employees would test positive for COVID. I mean, if that is true, and it very well may be, because after Tyson did an investigation at the plant, they fired 7 managers. And so those allegations very well could be true. And if so, that is pretty loathsome to think that they would have a betting pool in the plant about how many of their workers would end up being sick. But the tort claims, I frankly would be surprised if they ultimately result in any type of a damage award. For the reasons I give here. One, there's the workers' compensation bar that they have to overcome, usually in tort litigation against employers. Many states now have, about a third of the states have COVID liability shields. I think Wisconsin just enacted one either earlier this week or last week, which provides a broad shield against liability arising out of COVID infections. And even in states that don't have such shields, causation is going to be a very difficult hurdle for the plaintiffs to prevail. And then federal preemption is also a likely defense that will be asserted as well, particularly after President Trump deemed the meatpacking industry as a critical as a critical industry for our nation. So there are a number of tort cases that have tried to, they're trying to recover for these damaged individuals. Now, what is Congress doing? Well, Congress only recently, through the coronavirus subcommittee, has requested information from from several of the major meat producers and packers in the country, including JBS, Tyson Foods, and Smithfield. And has also requested information from OSHA about its enforcement of the OSHA Act in the meat processing industry during this pandemic. And this just a letter, Representative Clyburn just sent a letter early this year. So this is still playing out. Now, talk about meat processing, but the seafood sector too has been affected by COVID. And here too, if you were to look at the workforce, it is not nearly as driven by people of color, but still it has disparately affected those who are employed in this industry. In fact, the outbreak at the Trident Seafoods plant in Alaska, which is the North America's largest seafood processing industry, was closed and recently opened last week. And then there have been other complaints of inadequate workplace conditions in seafood processing plants throughout the country, including Oregon, Massachusetts, and Rhode Island and Maine. So what can we do about this? Well, I think vaccinate. That is crucial. And I think best I can tell, since each state has a different vaccination program, only about between 13 and 20 states only have frontline food workers at the head of the line to get vaccination. I also think we should show these people some love and gratitude. I mean, they really are risking their lives in order to feed us. I think we need to improve the data collection so that we understand just how widespread COVID is within the employees who work in this area. And then I also think that OSHA should make food processing an enforcement priority. And there's a provision referred to as the general duty clause, which gives OSHA a lot of authority to enforce workplace safety overall. Then I think each of us needs to consider what we eat, where and how it's produced. Then another thing that I think can be done is slow down the production lines. And then finally, this summer, grow a vegetable garden and do yourself some good by feeding yourself. So thank you, and I look forward to your questions.
Thank you so much, Professor Latham. Just as a reminder, if you have any questions, feel free to type them in the chat on our Vermont Live page, or if you're watching in on live Facebook, feel free to comment and we'll get to those as soon as possible. And our last presenter of the night is Dr. Mercedes.
Can you hear me?
Yeah, or at least I can.
Great. I turned off my video so I can share my screen. Can you see my screen?
Yes.
Perfect. Thank you. So I'm going to switch now the presentation into looking at Vermont racial disparities and the impact of COVID-19. I'm going to give a brief introduction on racial disparities and where we are related to the impact of COVID-19 on communities of color. And then I'm going to share some findings from 10 focus groups I did in the fall with immigrant and refugee communities to assess the impact of COVID-19. And finally, I'm going to share about the vaccine clinics that we are running currently and the vaccine education sessions for communities who are limited English proficient in the state of Vermont. So I'm going to start by sharing some data related to COVID-19 and racial disparities. For those of you who are following the data from the Vermont Department of Health, Black Vermonters are overrepresented among COVID-19 cases in Vermont. They make up 1.4% of the state population, but 14% of confirmed positive cases. 1 in 5 cases in Vermont are people of color, and Black or African American Vermonters have the highest rate, followed by Asian and Hispanic Latino. And for those of you who are following racial disparities in Vermont, I've been doing many interviews this past year through VPR and also on TV. We also need to acknowledge that the Winooski, Vermont outbreaks here in Chittenden County were directly connected to failure to provide information in real time to communities that fall under the definition of limited English proficiency. So information.
Sorry, Professor, one quick thing. Could you make sure they are live? Thank you.
I'm sorry?
The slides weren't forwarding when you were speaking, so just making sure they're all good.
Oh, thank you. So as I was saying, one of the important aspects of racial disparities in Vermont related to COVID-19 is looking at what happened in Winooski with the Winooski outbreaks, because information did not reach communities in a timely manner, and specifically information translated in different languages did not reach the communities until it was much later in the spring, May, and even in the summer. So that was directly connected to the two Winooski outbreaks. Also keeping in mind that we live in the second whitest state in the country, so these statistics related to COVID-19 racial disparities make the issues much more salient and alarming, considering that our populations are small, yet they represent the largest populations of COVID-19 positive cases. So the next slide I have here show racial disparities in children in Vermont. As you can see, among positive cases of COVID-19, almost 70% of positive cases in children under the age of 9 were children of color. And under the age of 19, it was 56% of children who identify as racially diverse. And even if you look at this chart and the age breakdown, you see disparities across the age bands. In every age category, we're seeing disparities related to COVID-19. So the three previous presenters have been talking about COVID-19 and the impact of systemic racism in COVID-19. For many of you, you might have seen that COVID-19 is called by many public health entities the racism pandemic. And this is a chart that we have from CDC, and I'm going to focus on underlying conditions. I know the other presenters talked about underlying conditions, and this is a chart from the CDC that breaks down race, gender, and underlying conditions, and they define underlying conditions as having diabetes, hypertension, asthma, and other chronic health problems. Also important to understand that underlying conditions is one of the categories for receiving the vaccine earlier than other age groups. So important how we define underlying conditions, and each state is defining underlying conditions differently. And I've been advocating in Vermont for using a social determinants of health framework for underlying conditions, because we need to understand, which is the next part of this slide, we need to understand that underlying conditions are also the direct result of exposure to poverty, redlining, gentrification, food deserts, healthcare disparities, and most importantly, environmental, structural, and systemic and institutionalized racism in the United States. So having a critical thinking and emotional intelligence lens when we address when we define chronic health conditions and underlying conditions, and when we identify the groups that are going to be receiving vaccines in our state and nationally. I also include in my presentations, I've done workshops across the United States related to understanding the connection between racial disparities and health disparities. So this slide, and I can put all the different findings from the slide. This slide shows the results of 7,500 providers who completed a pre and post test related to the health equity workshops I do across 27 states and in 150 organizations. And one question that we ask providers connects to diversity experience. So we asked providers whether how much training they receive in their lives related to equity, multiculturalism, diversity, inclusion, and 36% said they received none to a little. So we need to understand that ongoing education and training around understanding health equity and health disparities is one of the key aspects of addressing and eliminating health disparities. And the next two biggest findings from my research look at knowledge gaps for providers that attended my workshops, and one of them is racial disparity knowledge. So most providers who come to my trainings did not know the history of racial disparities, and then they didn't know how racial disparities are directly connected to health disparities. I always share in my presentations that I spent most of my career teaching people who were born in the United States the history of the United States more than I teach about health equity, because my work focuses on educating the public and providers around the history of racial disparities. So the root causes of racial disparities in our society and how those racial disparities and the historical events that created the racial disparities are directly connected to today's health disparities. So my research is not new. This lack of awareness related to health disparities has been researched and studied since the early 2000s, and this is one of the famous studies that found that the majority of providers were unaware of disparities. They attributed disparities to the patient rather than the provider, and they questioned the validity of studies finding racial disparities in healthcare. Why is this important related to COVID-19? Because COVID-19 has resurfaced many racial disparities that existed for a long time in the United States. It's not new what's happening with COVID-19. It's just that COVID-19, when we have a public health issue like what's happening with COVID-19, that resurfaces many of the disparities and inequities that exist in a society. And COVID-19 is one perfect example of resurfacing racial disparities at the intersection of health disparities. So let me go briefly through the focus groups and vaccine education sessions and that we've been doing in Vermont. These are the findings and recommendations from the focus groups. We did 10 of them, interviewed 107 community members from former refugee and immigrant communities. The biggest findings had to do, which is probably not surprising for anybody watching this presentation, being able to provide easily accessible forms, and this related to vaccine clinics, related to testing sites, and reducing paperwork. We found that when families had to access a clinic or a testing site and they had several family members, each family member had to fill out at least 4 pages of paperwork to be able to be tested for COVID-19. And that caused so many barriers for families to have an interpreter there that is required by law, but the time it took to complete the paperwork. So one of the recommendations from the community is to reduce paperwork and ensure that any registration form is easily accessible and in plain language. We also need to ensure that we improve interpretation and translation services as required by federal and state law. I continue to see violations related to not having interpretation and translation services for limited English proficient patients. And this has been an issue for a long time in Vermont and nationally, but it's something that we need to continue advocating to ensure that language access becomes a priority for limited English proficient populations. We also need to train providers in health equity models. We need to expand community outreach and education via trusted community leaders. We need to implement community-based clinics, have more direct engagement with communities from public officials, and we need to provide funding for cultural brokers, community health workers, and outreach positions. Those are some of the best practice models in addressing and eliminating health disparities. I also wanted to share with the group that starting now 4 weeks ago, we started implementing, you probably saw this on the news, we call them community clinics, vaccine community clinics for limited English proficient patients. So we are following the same age band that the state of Vermont is following, but these community clinics happen in Burlington, at the Association of African Living in Vermont, and then in Winooski at the Winooski schools. And we provide vaccines for all the community members that fall under that age band and all the household members that live with that elderly person in the same address. And if they all come together to the appointment, everybody gets the vaccine. Again, these clinics are community clinics for limited English proficient patients. We're looking at expanding this into other communities that have been disproportionately affected by COVID in Vermont. And I included here, based on the previous presentation, that no ID, no documentation, no paperwork or any type of ID is required to come receive a vaccine. And the main reason for this is because we're all looking forward to having as many people vaccinated as possible. So we want to reduce any type of barrier that can prevent community members from accessing vaccines. The other aspect I've been advocating for, I'm part of one implementation team that we meet 3 times a week to address some of these issues. And another aspect I've been advocating for is for the underlying condition and chronic health problems to do not require any type of documentation. There is some concern at the state level that some people might lie about their underlying conditions. And my response to that, which I voice it in every meeting, is that many people in our society have been cheated by the systems that have been created to leave so many people behind. So if people want to cheat the system in a way to access a vaccine, which our goal is to vaccinate as many people as possible, I mean, I'm fine with that. And the other aspect of a public health approach for vaccination is to ensure that we make healthcare accessible to all communities. We live in a society where healthcare is a privilege and not a human right, as it should be. So we've been having all these conversations regularly, and hopefully there's not going to be any documentation required for community members to have to prove that they actually have a chronic health condition or an underlying condition. So regarding vaccines, we have conducted 13 educational sessions in 16 different languages since December. There are 4 more scheduled in March for migrant workers, Jamaican and Spanish-speaking migrant farm workers. The majority of community members are anxiously awaiting the vaccine, and they claim that they would take the vaccine from the sessions that we've done, although they did have concerns related to side effects, related to cost of the vaccine, which the vaccine is free for anybody in Vermont. And there was a specific distrust for the vaccine reported in the Congolese and Somali community, rightfully so, because of the history of unethical medical experimentation globally and in the United States with Black and African American communities. There is also, there are also videos and through social media targeting these communities across the globe and also in Vermont and in the United States from anti-vax groups, and providing misinformation about vaccines that we try to address at every educational session. So the impact of the vaccine educational sessions is, after the first 4 sessions we did, we saw a dramatic increase in interest in getting the vaccine, and that was due to cultural brokers, community outreach workers, interpreters, and school liaisons. And this speaks to the importance of community outreach and community education, and how important it is to address concerns and misinformation that communities can be obtaining through different means, especially social media. We are advocating to continue community clinics, expanding to other communities. Tomorrow, we hope that in the press conference, they're going to announce some changes into expanding community clinics to other communities that have been disproportionately affected by COVID-19. Addressing barriers to ensure that anybody who is an elder can access the vaccine. And I don't know if any of you have had to help anybody register for the vaccine. I had to help my mom because she doesn't speak English to register for the vaccine. And it was actually a nightmare to complete the registration form online. So if somebody who is over 70 or over 75 doesn't have an email address or a cell phone number, a code is sent to you, you had to verify the information. So those are all barriers that prevent community members from being able to access the vaccines. We need to continue community education and vaccine to address vaccine concerns and address concerns and questions that communities have, provide access to vaccines to teachers who serve the most diverse school districts. Of course, we should expand vaccines to all teachers, but specifically to be able to address the children that have been disproportionately affected by COVID-19, essential workers. I mean, all the previous presentations show that we need to be providing vaccines to essential workers as soon as possible, and all in BIPOC communities. I've been advocating in Vermont to adjust the age band. We know that African Americans, Latinx, and indigenous people, we are dying younger due to the impact and exposure to systemic racism nonstop in our society, and we're dying younger compared to white communities. So many of us have been advocating to adjust the age band. So if we are vaccinating 70 and older, 65 and older, we should be vaccinating 60 and older or 55 and older, depending on life expectancy for these communities. We need to expand vaccines to household members for housebound community members. So when we have a nurse going into the home to provide a vaccine for an elderly person who cannot access the clinics because of mobility, we should be able to vaccinate everybody in that household who is older than 16, which is the age group we are. Anybody who is older than 16 can get the vaccine once their age band opens. And finally, my biggest call to action is to ensure that leaders continue to advocate for systemic change and speak up against systemic racism and any other form of discrimination. If any of you had the opportunity to watch, these are some of the interviews I've done since the summer, and some of the blogs and some of the stories I've written about COVID-19 and racial disparities. And I specifically encourage you to watch the House Healthcare Committee testimony that I gave yesterday. It was a 2-hour testimony on health disparities legislation H210 that addresses many of the pieces I presented today, and is also one example of the work that we need to be doing to ensure that across the state of Vermont we are effectively addressing health disparities and inequities. So I stop sharing now, and that should bring me back to the screen, correct?
Oh, I'm on the screen now. Thank you so much for that information. Now we're going to move on to be adding more questions as we ask them and as we go. So the first one is focused for Dr. Tai and Dr. Mercedes, and it says, given the data showing the disparate impact of COVID-19 on people of color, should those data be taken into account in the distribution and administering the vaccine? So kind of what we've already talked about, but do you have any more information you'd like to provide?
I guess I can go ahead. I really like the idea of Dr. Avila. For sure, she has done a ton of work on this. The idea really is the term equity, more than equality. That's basically what she was trying to get into. So because some groups of people are already way behind, so you're gonna try to overcompensate. So I I probably would ask Dr. Avila what she thinks would be the best measure to try to catch up and, try to make sure that we vaccinate them in a way that it's equitable. And I really like the idea of the different age cutoff, because that makes sense. If, if there's a different health impact, you opened it nicely saying that, the decrease in the length of age expectancy, basically life expectancy, has hit BIPOC communities like harder.
Thank you. And just briefly, I would add that the Vermont Racial Justice Alliance has written a letter requesting BIPOC communities to access the vaccine based on the disproportionate impact of COVID-19 in communities of color. So that is a letter that is available to the public as well, and has been sent to the governor and Commissioner Levine, and hopefully tomorrow there are going to be some answers to that request.
Thank you. Our next question is open to anyone, whoever wants to speak on behalf of it. It says, what can be done to combat misinformation about the vaccine in the distrust, especially among African Americans in the government, given the history of the government mistreatment? And they provided an example of the Tuskegee study where Black men with syphilis were promised treatment but did not receive it.
Well, I think the short answer is quit watching Fox News. But in a more serious vein, I think people have to be very careful where they get information. I mean, we should listen to the physicians and the scientists, and not some bonehead TV newscaster about the pandemic. We should listen to the experts. So I think that would help. I would also think that the type of community outreach that Dr. Avila's doing, which is really remarkable. So thank you. That could go a long way too, I would think, to combating misinformation.
Can I add that it's really a retail job, right? It's working with people at the community level. It's listening and respecting their concerns, and engaging in conversations. There's actually been a lot of studies about how to engage with people who are uncertain, hesitant about vaccinations. And we should not focus on the people. There are those who are adamantly opposed and are trying really hard to spread disinformation, but address the concerns. And I think Professor Latham is right too. Trusted healthcare providers, whether they're doctors or nurse practitioners, who people have relationships with, are often the best person to engage with people. Unfortunately, right now, because we're doing vaccinations so much at a sort of wholesale level, that's hard. We really need to make it retail and get people talking to people they trust.
Yeah.
I'd like to add, sorry, there go.
No, go on.
I think community leaders are very strong powers in the community, especially in minority communities. And we've seen this before very early on in the pandemic. Doctors are horrible at marketing and PR, and we're always losing this information campaign. And then we sort of didn't realize, for example, Black churches, or like pastors in Black churches, like they're really important part of their community. So we have to go into who's their leader, who's trusted in these communities. I think that's a really good place to start. And there was even, because you have to look at the whole social context of this, it was funny actually, because, Americans didn't really think this is serious until the NBA got canceled. A lot of my friends were like, oh my gosh, it's serious. The NBA got canceled. They didn't even, so there are like some social aspects to this that, we have to pick up.
Yeah, and I think as a follow-up to that, given our celebrity culture, love it or not, there's a role for athletes. I think, like African-American basketball players could make public service announcements or commercials and stress the importance of vaccinations and that they're, safe and effective. Along with your comment, Geno, about the importance of ministers in the Black community. So I think a combination of a variety of strategies and tactics can be used to get the word out that if you have an opportunity to get vaccinated, or when it's your turn, get vaccinated, because that's how we're going to get to the other side of this terrible, terrible pandemic.
Thank you all. So this one is for Professor Parmet. Wendy, having done work litigating for a disease with social stigma against a particular community, what are some parallels that you have observed between your previous work and the current COVID pandemic? How has misinformation been handled differently through your career, and what do you hope to see in improving misinformation?
Well, it seems like there's a couple questions in there. Let me address stigma first. Yeah, stigma is a common feature of disease and pandemics, and especially novel infectious diseases, right? So I began my own work during the AIDS epidemic, and talk about stigma. It was a very stigmatized disease, and communities were stigmatized around the disease, right? So the stigma that attaches to a disease is often felt by a broader community, often including people who are not, in fact, infected. This is a feature. And stigma also interferes in many ways, really undermines our ability to fight disease and to follow public health measures and to engage and have the kinds of supportive programs and social solidarity we need. And that was very clear in AIDS, and we could go through pretty much every disease. There's a lot of stigma around Ebola. COVID is interesting. There certainly has been a lot of stigma, and we've seen evidence of a lot of discrimination against Asian Americans, right? The fact that President Trump and many of his supporters continuously called the disease, the coronavirus, the China virus. So there has been discrimination, there has been stigma, but COVID is funny in that it is the politics and salience and social meaning of COVID is, on the one hand, there has been stigma and discrimination. On the other hand, there has also been, I think, in contrast to some of these other conditions, often with pandemics, we see sort of panic and we see a heightened fear. And what we've seen here, and much of the misinformation, is not about exacerbating fear, it's about actually, diminishing the virus's lethality, right? It's just the flu, it's not there, it's a hoax. And so the politics of COVID and the way it has played out has led to this, I think, rather remarkable situation where, on the one hand, there is some stigma, I'm not, definitely there, and always potentially possible to break loose and become greater. But on the other hand, there's really been a diminishment of COVID. There's another kind of stigma, and I just want to sort of briefly mention, which is, and this one is connected to the it's no big deal, which is, if you get it, right, you must be weak. See, healthy people who, and this is very much affected, right, with the social determinants and racism. Communities of color are being afflicted more because, you know, they engage in unhealthy behaviors, they smoke or they eat unhealthy. And we've seen this often in our society where we blame disease on the people who are ill. We assume that people who do the right things, who live right or whatever it is, right, often which is a sign of inner factor of privilege, right, that people can afford good food or avoid the virus, that it's a sign somehow of moral failing. So that's another form of stigma. And we've seen this in the disease. There certainly also has been ageism. And a lot of, we could talk about that for a long time and how, you know, people who, well, it doesn't matter if they die, you know, let's open up and, well, older people go. So there's been that. The misinformation question is a longer, different question, and it's really challenging, right? We have a very strong tradition of the First Amendment. A lot of people have talked about different ways. So we've always had misinformation about disease, right? We've had misinformation about disease probably since the beginning of human history. What is different, I think, now is one, social media and the way that misinformation proliferates and the way more and more people are sort of getting all of their information in their own bubbles, right? Which proliferates the misunderstanding. And secondly, again, the public official statements of misinformation, right? I mean, the fact that public officials from the president, the former president, on down to many others, explicitly, they gave an imprimatur to misinformation. And that's really quite unique. We could talk about this for a long time. There's no magic answer to this, right? The toothpaste of social media is out of the tube, and it's going to be very hard to knit it back together.
Thank you. All right, so this will be the last question of the night, and that is, what resources can people use to dive deeper into these issues, such as the discussion of health disparities in communities of color?
Well, I think one helpful source is the CDC's monthly, the monthly morbidity and mortality reports. Those have a wealth of information about, I mean, just a ton of statistics about COVID and its effect on different populations, including people of color. So I think that's one source that people can turn to.
I would say, you know, it depends on how specialized or what kind of journals you read. For sure, for me, infectious disease and medicine in general, we use the medical journals. I'm sure there are a bunch of other journals which the other professions use, which talk about this topic, which I don't know all of them. For sure, social sciences would have them, or like psychology, all of the other professions. But the medical journals probably would definitely talk about them.
And I would expect that you will see a ton of law review articles forthcoming about various legal aspects associated with COVID.
Yeah, there's a very rich legal literature now. I just also want to plug, since I'm one of the editors of the American Journal for Public Health. We've been publishing a lot on these issues from a public health perspective.
Well, that will conclude today's discussion. Thank you all so much for joining us virtually, and thank you all so much for listening in. For more questions about embedded racism in the law series, or to reach out to these panel members, please contact the VLS Diversity Committee and we can get the proper information. Again, thank you all so much. This was really insightful and wonderful. Everyone stay safe and warm out there.
And thank you, April, for moderating.